arthroscopic transtibial pull-out extrusion reduction sutures, an effort to reduce persistent meniscal extrusions. Surgery was performed by Associate Professor Dr. Bancha and presented by RenaldiPrasetia. Disclosure: Author has no conflict of interest with regard to this technique. 55-year-old female came with chief complaint pain on left knee joints. From MRI evaluation, we found from the fat suppression T2 corneal view show meniscal medial extrusions more than 3 mm, and from the fat suppression T2 corneal view show cleft sign, and fat suppression T2 sagittal view show ghost sign at posterior root medial meniscus. Then we perform arthroscopic diagnostic, and we found intact anterior cruciate ligament and also intact posterior root lateral meniscus. To open joint space narrowing on the medial side, we perform pie crusting of posterior oblique ligament, and then we found radial tear at the posterior horn medial meniscus extend to posterior root medial meniscus. Then we decided to perform posterior root medial meniscus repair. We identify and debride attachment of the posterior root medial meniscus with arthroscopic shaver and curettage. We insert drill guide as a low-profile construct devices. And then we creating posterior root medial meniscus tunnel with 2.5 guide wire, followed by rimming it with 4.5 endobutton rimmer, and insert number 2 PDS as a shuttle relay. And then we insert number 2 ultrabait with a true pass device to the posterior root medial meniscus. And we change it with ultra tape using number 2 ultra braid as a shuttle relay. And then we insert free end limb into loop end limb and pull it out to make a cinch configuration. After that, we perform arthroscopic transtibial pull-out reduction sutures. We're creating first trial reduction sutures with insert number 2 ultra braid using true pass, and then change to ultra tape using ultra braid as a shuttle relay and creating cinch configurations. After that, we perform creating second trial reduction sutures with number 2 ultra braid and change to ultra tape using ultra braid as a shuttle relay again. After we try to pull and reduce, we release one cinch sutures and make sure that the loop end on the superior meniscus and retrieve all the suture and limb to the anterolateral portal and creating horizontal mattress configurations. And then we insert drill guide and creating tunnel with a 2.5 guide wire, follow with rimmer with 4.5 endobutton rimmer, and insert number 2 PDS as a shuttle relay. Then we retrieve 2 free end limb with a number 2 PDS to the anterolateral portal and insert the 2 free end limb into number 2 PDS and pull it out into the tunnels. We can add posterior root medial meniscus chin stitch as necessary, and then we retrieve number 2 PDS and all free end limb to the anterolateral portals and insert all free end limb into number 2 PDS loop, pull it out so that the ultra tap inside the tunnels. And then we make anterocortical fixations using endobuttons. There are several causes of failure in posterior root medial meniscal tear repair to reduce meniscal extrusion. First, Repair only facilitates indirect meniscal extrusion reduction and fixation so as to create the ineffective distance and direction force to reduce meniscal extrusion. Second, the rigid anchorage of medial capsule and meniscotibial ligament to maintain extruded medial meniscus in chronic posterior root medial meniscal tears. Third, meniscus have tensile capacity to elongate so that the indirect force of the posterior root medial meniscal tear repair only create meniscus elongation than reducing meniscal extrusion itself. Additional transtibial pull-out extrusion reduction sutures has a benefit to overcome these issues. First, this technique facilitates direct meniscal extrusion reduction by creating effective distance and direction force to reduce meniscal extrusion. Second, this technique will minimize tension of posterior medial meniscus during posterior root repairing because meniscus have already been centralized. Thank you very much for listening.